Ellen Baker is now going to share the perspective of Project ECHO at University of Texas MD Anderson on the potential for telementoring to extend oncological pathology and imaging to the community.
Thank you. Just to sort of start, we've heard today largely about the challenges within the specialist community. And of course, specialty training and expertise is critical to the diagnosis and management of patients with cancer. We've also heard that access to specialty care is an issue, and the distribution of expertise in the United States and outside the United States is certainly not even. I think Otis brought that up first thing this morning. We've heard that teamwork with specialists is a good way to provide feedback and coaching for those who don't have that sort of training. And so I'm going to talk a little bit about something called Project ECHO. The ECHO model is just one tool that it could be used to disseminate knowledge and also to build capacity in regions where the subspecialists and even the specialty is not available. And in thinking about that, think about what skills and what competencies are really needed out in the community that aren't there presently. We obviously can't duplicate what's available at the major cancer centers in every community in America, but is there some middle ground where we can improve what's currently available and provide resources to these communities so patients get better care and the physicians have more support? I have no financial relationships. So just a little bit of history of Project ECHO. It was started by this guy, Dr. Sanjeev Arora. He's a gastroenterologist at the University of New Mexico, and he wanted to develop a means for people to get access to specialty care when they need it in their communities for complex and treatable diseases. And he started this effort about 13 years ago in New Mexico, largely a rural state. There was about 30,000 patients at the time who were estimated to be infected with hepatitis C. The treatment at that time was quite toxic. And if you had hepatitis C in New Mexico, the only places that you could be treated were in Santa Fe or Albuquerque. Dr. Aurora's clinic had a wait time of about 8 months. And of course, it required multiple trips to the doctor. So if you live 200 miles from Albuquerque, you might have to make that trip 12 or 14 times a year. So he went around the state and partnered with 16 rural clinics and 5 prisons and said, let's start this partnership. We can talk on a regular basis. I'll be your mentor. We'll bring in a multidisciplinary team at the medical center, and let's see if we can demonopolize knowledge, but provide the support that you need to care for patients in your own communities. So he conducted regular conferences, and he was able to train providers, frequently the only provider in the community, in addition to nurses, physicians' assistants, et cetera. He did his conferences based on case-based guidance. So the partners in the community would present cases, they would all discuss it. It was a very level playing field. He was not just delivering the knowledge in one direction. Everybody discussed it. He had a much better idea of what the challenges were in providing care in the community. And he collected data and monitored outcomes. And after 3 years, looking at about 400 patients who were treated in the community, was noted that their cure rate, their sustained viral response, was pretty equivalent to that at the university in Albuquerque. In addition, to improve patient satisfaction because they were able to receive good treatment and didn't have to trek back and forth to Albuquerque, the providers felt that they now had some backup, a professional network. They were able to manage their patients in their community much better, and the wait time in Dr. Aurora's clinic went from 8 months to 3 weeks. And so it's the first couple of years we did this at MD Anderson. Anytime you talked about ECHO, it was misinterpreted as telemedicine. It's not the doctor to the patient. It's providers, physicians, nurses, et cetera, all talking to each other. And so we call it telementoring and not telemedicine. And the idea is that this way you multiply the effect that you might have in providing and disseminating this knowledge in the community, with the thought that your partners out in the community will then be able to treat many patients instead of you just being able to treat one patient. So this idea really has taken hold, and I'll tell you a little bit about that later, but the goal is to take that knowledge that usually sits at the academic center and share it with the rest of the medical community, particularly areas that don't have that specialty or that knowledge. And in doing this, build capacity outside the major medical centers to treat patients very safely with diseases and complex conditions that might otherwise have bought them a referral. And obviously, it would be difficult to do this for every condition, but I think there's a number of complicated medical problems for which this model actually can be quite effective. And in doing this, also reduce disparities so that patients who might not normally have access to specialty care now have indirect, if you will, access to specialty care. So ECHO is just a video conference. There's nothing really magical about it. It follows a particular format, and that is that we use technology to leverage scarce resources. We find that using a video conference instead of a telephone conference is really orders of magnitude more powerful. It allows you to get to know each other in the way that a phone call does not. It shares best practices to reduce disparities. It uses case-based learning because Dr. Aurora feels that this is a much more powerful way for people to learn, and you monitor outcomes. The format is very simple. You choose the frequency with which you think you might like to have a conference. We have some at MD Anderson that are weekly, some that are every other week, some that are monthly. Again, it's case-based, so your partners in the community present cases. We like to assemble a multidisciplinary team at MD Anderson, and we encourage our partners to assemble as much of a multidisciplinary team as they can as well. And everybody works together to provide best patient care. We generally offer short didactics to complement the case discussions. We provide free continuing education for nurses and physicians. And again, we've been doing this for now several years. So the benefit is to the patients. They get treated in their local community. They don't have to wait 8 months to see Dr. Aurora. The providers actually have been quite satisfied with this, and now, particularly those in isolated areas, now feel like they are part of a professional network. They have some backup. They can send an email or call one of the doctors at MD Anderson if they have a particularly complicated case, and there's already a nice relationship among everybody. And then within the community, disparities hopefully are reduced and the system operates a little bit more smoothly. So we brought Project ECHO to MD Anderson about 4 years ago, primarily directed at cervical cancer, largely a preventable disease, not very common in the US anymore, but of course very common in many other places of the world. About 85 to 90% of cervical cancer cases actually occur in the developing world now. But one part of the developing world is actually the Texas-Mexico border, where the rates are quite high. The access in the public system to specialists does not exist. There are no gynecologic oncologists in the public system. And of course, the population is very poor, and there are many uninsured. And the goal of this project was to partner with the federally qualified health centers down there to provide specialty guidance in the management of women who have cervical dysplasia. And I'm an internist, and I thought, how complicated can this be, really? How long are we going to talk about management of abnormal PAPs? But in fact, I learned something new every time, and we've been doing this for 4 years. So we do this every 2 weeks. And the providers down there don't get paid. They show up every 2 weeks. We've had very good participation, and it is a part of a much larger project that we have now to reduce the cervical cancer burden down there. Our tobacco treatment team at MD Anderson is partnered with local mental health clinics around the state of Texas to provide tobacco treatment guidance for patients with mental illness who, as you know, bear a great burden of tobacco-related disease and are frequently not in the conversation when we talk about tobacco treatment. We have a couple of ECHO projects on survivorship, one in training family medicine residents in cancer survivorship, and another working with community health workers to provide support for cancer survivors in living activities, physical activity, and diet and nutrition. And then our projects that are more traditional in terms of cancer are the ones that are global. We have a palliative care ECHO that's partners our palliative care team with those interested in palliative care, some specialists, some not, in 5 different countries in Africa that runs once a month. We have an early melanoma diagnosis at MD Anderson that's partnered with academic centers within Texas to use dermoscopy to do a more accurate assessment of lesions that ought to be biopsied and are likely to be melanoma. We have a very active program in Mozambique that we run with partners from Brazil. It's conducted in Portuguese, and it started with cervical cancer, and the physicians in Mozambique have urged us to include now breast cancer, head and neck cancer, lymphomas, and pathology. So we actually have 5 different ECHO programs in Mozambique. We have 10 gynecologic oncology teams, actually from 10 different countries, gynecologic oncologists in Central and South America that participate monthly to discuss gynecologic cancers. Quite interesting because you have high-income countries like Uruguay and you have El Salvador and Guatemala all on the same call, all learning from each other and learning the challenges in their community. And recently, the International Gynecologic Cancer Society has started a program to train gynecologic oncology fellows in regions that do not have this training, and the ECHO model is part of this program. The DaNang Oncology Hospital is supported by a mentor from Mayo Clinic Jacksonville, and Maputo Central Hospital is supported by 2 gynecologic oncology programs in Brazil, and Moi University in Eldoret, Kenya is supported by the University of Toronto. And ECHO is obviously not a strategy that is a standalone implementation. It's part of a much larger strategy to improve diagnosis, improve prevention, and improve management of patients with cancer. So ECHO is just one tool, and I kind of look at it as the glue that holds a lot of these parts together. We heard a lot today about communication, and it's actually a really excellent tool for communication. The fact that it follows kind of a standard format across all of our programs, I think is very helpful. It means that everybody's got the same expectations, and we know how the conferences will run. And it's, again, part of a larger strategy, particularly overseas, where we're working to strengthen health systems through a variety of means, and also to improve capacity. So the IGCS program is really a capacity building program to train gynecologic oncologists, but the other programs are as well. In Mozambique, we started with ECHO. We've grown to include technical assistance in writing their national cancer control plan, development of research capability, and then the migration of some of our activities outside of Maputo, the central main hospital in the country. The NCI Center for Global Health is using this model now in partnership with low-income countries and countries that do not have cancer control plans, and this is a tool they use to provide support and a forum for discussion to help local ministries write their national cancer control plan. So globally, it's moved from hepatitis C to many, many different disease entities. I think there's about, here we say 170 hubs, more than 65 diseases, 23 countries, There are now 10 echo training centers outside of the University of New Mexico, and MD Anderson provides echo training with a focus on oncology. So the general goal is to move knowledge and not patients, and to move that knowledge out of the academic centers and to other parts of the world. We talk about silos, but it's a big world out there, and there's certainly a lot that we can do with some of our very simple interventions. And just in case you thought the Earth was just the only place there is, that's the Earth from Saturn. We're just a little blue dot, nothing really special. Thank you.